Disability in Huntington's. This is a very small group. Please feel free just to interrupt me, to talk, to ask questions. There's no need for formality. Dr. Mary Edmondson was originally scheduled to present today's topic, but Mary wasn't able to come today, so she asked, very happy to present her slides. But this is all her work. In terms of conflict of interest, not much. I work for no drug companies. I work at Carillion Clinic in Virginia Tech. So I wanted to talk a bit about how common are suicidal thoughts, particularly in Huntington's disease. What are the risk factors? How do we reduce the risks? Talk about safety planning, medical treatment options, as well as resources. So, suicide is way up there on the list of really uncomfortable topics. It just is. You know, choosing to end your life is something that makes everyone uncomfortable. And yet, it is part of the human condition. And death by suicide is something that's been occurring with greater frequency over these last 2 decades for a host of different reasons. It's always been part of the human condition, and is much more likely associated with a sense of hopelessness, when nothing can get better, when there's extreme continuing emotional distress, or extreme impulsivity, because all too often people can feel despondent in the moment, and if they're also impulsive, act on that without having had a chance to think about, do I really want to? Do I really need to? What are the options? Does this make sense?
Yeah.
So it's also important to recognize that for every person who dies by suicide, there are so many other people who have thought about it, and many who have attempted suicide to a greater or lesser degree. You know, it's important to distinguish between a behavior that's actually intended to end your life, as opposed to a behavior such as cutting yourself that we've seen, you know, occurring with amazing, sad frequency in many teenagers, or others with certain psychiatric illnesses. We're really talking not about all of those other issues about self-injurious behavior that isn't intended to end someone's life. That's a whole other topic, and if we have time and anyone's interested, we can certainly discuss that. But that has much less relevance. This is
There you go. Give it a second.
okay. Okay. It's like motion lights. You know, you gotta dance to keep them on. Okay. So bottom line is, for everyone who dies by suicide, there are probably a couple of hundred people who have thought about it. Spoiler alert, but the bottom line is, you're not going to cause someone to attempt to kill themselves by asking them, are you thinking of hurting yourself? That is not going to happen. You will not make that happen by expressing your concern. So, the third leading cause of death of people with Huntington's disease is death by suicide. So, it is important to recognize that, you know, about somewhere around 10%, between 6 and 13% of people with symptomatic manifest Huntington's disease die by suicide. Almost a third of people who know they have the gene but are not symptomatic, otherwise perfectly okay, are thinking about it, fearing the future. And so it's important to recognize this isn't rare. it's important for us to be comfortable discussing it, however unpleasant the topic may be, because when we talk about the fear of suicide, we, in the same breath, are really talking about the potential for life. So these are just some of the numbers in the bar graph, just those with. So what it expresses is that people, half of everyone who is a gene carrier for Huntington's will have some thoughts of suicide during their lives. And the two high-risk periods are in stage 2 and stage 3. So in particular, when people are, in terms of neurologic exam, definitely they're starting to have some symptoms that might be consistent with it, or they definitely do. Whether it's based on neuro exam or on total functional capacity, it's as things are beginning to progress, those are the really high-risk periods. So knowing that empowers us, because we know in advance of that, it's important to talk about it and to feel comfortable talking about it. So what are the risk factors associated with someone thinking about killing themselves? Well, certainly, there are genetic factors, we know that. And that, obviously, is throughout the lifespan. Family history. If a family member has died by suicide, that, in many ways, normalizes it, reduces the distance, and makes it a little bit more intellectually and emotionally acceptable as an alternative. So family history is an important element to be aware of. Early life adversity is something associated with so many psychiatric illnesses, and it's certainly associated with the risk of a sense of helplessness and hopelessness. Going through neglect, sexual abuse, physical abuse, violence, parental violence, drug use in the community, all of these kinds of things can contribute to having a sense of hopelessness that can contribute to thoughts of suicide. Having other psychiatric illnesses or substance use disorders clearly increase the risk for suicidal thoughts. But then there are so many other environmental factors. Not having significant social supports, feeling isolated, living on the edge of poverty, or indeed being homeless can escalate these risks. Serious life events, but also things like effects from the media. Hearing over and over again about the horrors in the world, the losses, the deficits, the fears, all of that can contribute to a sense of hopelessness, which is arguably one of the biggest concerns. So it's important to take all of these into account. Thank you. So, again, risk factors associated with the actual event as opposed to long-term risk factors. What might trigger it? People with active alcohol or drug use absolutely are at far, far greater risk of thinking about and attempting suicide. It's really important for us to recognize this, and wherever in our families, Huntington's or not, to address addiction and to make sure that people get the support and the treatment they need. Access to lethal means. The obvious, there are at least one gun per person in the entire United States, probably more in many states. So having access to lethal means is something that needs to be controlled and restricted. Locking the guns up, keeping the ammunition separate, all of these kinds of things. At some point it may be keeping knives restricted to access. So all of these things, just the basics, because again, some suicides may be thoughtfully planned over a period of days or weeks. The majority are actually impulsive. And so the impulsive suicides we can prevent by taking these very basic steps for reducing access to dangerous means. A new diagnosis can certainly add to it. If in addition to Huntington's you're diagnosed with cancer or another life-threatening illness, these are the kinds of things that are high periods of risk. And knowing that, we can take steps to support people during these high-risk periods. Does this make sense so far? Any questions?
Well,
Yes, please.
do you know what the comorbidity is between Huntington's disease and substance abuse? Is it higher than the general population?
Yeah, a lot of times it would be because people are looking to self-medicate as well. So a lot of times people are starting with like marijuana or getting into other drugs. So I don't know the numbers, the statistics, but there is a higher prevalence of people who do self-medicate.
And that certainly will correlate with not having access to treatment and to a treatment team. That absolutely, thank you. So there are lots of high-risk factors that we need to think about. And this is something that as caregivers, as family members, even for those who are self-aware, being aware of it yourself matters. Things like, what are the signs? Are they taking any actions? Hoarding pills, keeping a knife under the bed, or earlier on in the illness, buying a gun, with no prior interest in firearms. It's important to just think and reflect on what the concerns might be. Hoarding pills, very, very easy to do, right? And all too often, very, very challenging and problematic. So pay attention to that, whether you administer the pills, whether they're being self-administered, monitor them, watch for them. If someone is purchasing weapons or, thinking about it, like if you're walking with someone on the street and they pause and they're looking in traffic and they're looking around thinking about, it can almost be obvious about, could I step in front of that truck? Almost it is thinking about a dry run. These are the kinds of things that are really important to be able to stimulate a conversation. You're not going to be tying someone down to keep them safe. The thing that matters most is communication and creating a sense of hope and hopefulness. That's what we can do. Have there been previous attempts that people have tried? They may have stopped at mid-street. They may have taken the pills and that said, I just took all these pills and I changed my mind. We need to go to the emergency room to get my stomach pumped. That sort of thing. So if someone's done that already, it really means it's way past time for open and frequent communication. And so the distinction here between an aborted attempt, which is an attempt that someone stops themselves, versus interrupted attempt, where you walk in and stop them from doing something that might harm themselves. Both contribute to this. Yes? It certainly can be. Think about the process. Someone is feeling hopeless, helpless, and they don't have an easy, established means of communication. In a family that never talked about their emotions, we're in a family that traditionally just each person was expected to just soldier on. That might be the only way they think they can ask for help. So it's certainly not at all uncommon, which is why the underlying theme of this whole presentation is communication. Make sense?
Yes, sir, thank you.
Oh, and I'm Bob, not sir. So when we're thinking about this, what makes life worth living? Being sick doesn't mean that life isn't worth living. It just doesn't. Most of us live with some kind of chronic condition. And we're all going to die. Those are two things we know. So that in and of itself does not mean that it's hopeless. So what can we do to help at any stage of Huntington's make life worth living? What resources do we have? Are we sure that people have access both to the psychiatric or mental health care? They have someone to talk to who they feel safe with, who they can talk about their fears and anxieties. It could be a family member, but all too often people can be more comfortable talking to a professional who isn't so emotionally entwined. And also having access to a clinical treatment team who can help to address any of the symptoms that may be creating fear. I don't want to choke to death. I don't want to die because I can't breathe. All of these kinds of things. Knowing that the treatment team is there for you to support you, and that's not, that we will be able to take steps to prevent that from happening. All of that makes people feel safe. And if someone feels safe, they're going to be much more hopeful. Having a relationship with caregivers and providers. Again, we talked about removing the lethal needs, but maintaining strong connections to the community, to the family. So one of the opportunities, one of the sad things that can all too often happen is someone's becoming symptomatic. There may be a sense of embarrassment and then a withdrawal from extended family and friends because you feel embarrassed, whether it's the person themselves or the family. They don't want for people to think that their loved one is drunk all the time with all these uncoordinated movements or whatever it might be. They don't want them to experience a sense of fear. Can I catch it? It's so important to share with your family and friends who have been around for years what the illness is, what's going on, and how they can continue to participate as a friend, as someone who loves this individual, and not give up. Because if someone with Huntington's sees people around them, continue to love, continue to be there, continue to be friends, that is an enormous source of support. Many of us have strong spiritual beliefs. Technology is great when it works, and it's so frustrating when it doesn't. And whether it is in an organized church or in a group of friends, in an imam, with an imam in a mosque or a synagogue, whatever the spiritual structure may be, that can be a phenomenal source of strength for so many people and should never be something overlooked or ignored. If that's what matters to that person, that is such a source of strength. And it's important to learn. We keep learning. If we're alive, we can learn. And so learning new skills, both in terms of the support group, the clinical team, and the individuals, coming up with strategies that make it easier for people, to resolve conflict, to reduce, unnecessary emotional intensity. And just talking about, what are your cultural beliefs and what matters in terms of self-preservation. Why is it that you might choose or not choose? What, are you from a culture where it is horrible to even consider ending your own life, or is it one that is more acceptable under certain situations? But it's important to recognize that and to leverage it. So, number one issue is, before it's a concern, talk about it. Honey, I know you're not feeling this way now, but if you ever feel like life is not worth living, tell me. Let me ask you, and I will be asking you, I want to know because you matter to me. Setting the stage to make it easier as life progresses, that you can have these open conversations. And again, just to emphasize the point, asking about suicide does not increase the risk of it. Period. End of statement. It absolutely opens up a door for conversation. If the person with Huntington's feels you're uncomfortable talking about it, that's going to make it much harder for them to. If they know you feel comfortable talking about these really uncomfortable things, they're so much more willing and able to open up to you. Because none of us who love each other want to share things that are going to make the other person feel uncomfortable, or they think they don't want to hear them. And it's, in terms of what do you ask, what do you say? The number one question is, are you feeling hopeless? That's what's really associated with the long-term risk of dying by suicide. Feeling that there's no hope. You know, are they preoccupied with death and dying? Are they fantasizing about this way, that way to end my life? Do they actually have a plan? Some people will indeed have a plan. Separate from the plan and separate from the thoughts is how strong a desire or intent do they have to act on. So it's all of those things, the thought, the plan, and the extent of the intention that make up the risk of at least an intended act of suicide. This is called audience engagement. Okay. So, you know, just to be very concrete about it, a suicide attempt is any action taken with the belief that it will end your life. That doesn't mean that just because someone is taking 3 Advil, they may think that that will end their life, even if it isn't a high risk. It's also what their thinking is about the pills or the method, not just, you're gonna have to try harder than that, that's not enough. It's really important to understand what is the intent. The other thing to recognize is in Huntington's, there can be a lot, as we see all too often, planning, executive function, decision-making is impaired. And when someone experiences something, they act upon it. They're not going to think about it, plan for it as much. You know, early on in the illness, yes, there may be a planned, thoughtful approach to try to end one's life. But the most common approach is, at the moment I feel hopeless, I see an opportunity, I'm going to take it. And so that's why we're thinking as a team, the caregivers, the clinicians, how do we eliminate the risk of impulsive suicide attempts? Will make a huge difference. Because once you get past the 5 minutes, the 1 hour of high risk, we're back to normal. Because it's just that acute issue that can be addressed and overcome. So these are important elements to consider and to discuss. Again, the theme here is conversation and talking about uncomfortable things. One specific thing that can be done is literally safety planning. These things are downloadable from the multiple websites in terms of what are your safety plans. And the family can construct this together. What are the first feelings or signs? What would the individual do if they are capable of doing so to distract themselves? Or if not, what can you as a caregiver do to distract them? Who are the people who are most likely to be able to distract you? Can you call people for help? What is your most desperate moment that you can think of? How can you address that in advance? Who can you call? Plan for it. What can you do to prepare yourself, to keep yourself safe? And actually thinking about what matters to you. What makes life worth living? And really concretely articulate that. And it may change. It may change from January to June to December. But it's important to remember that whatever it is that matters is what we want to reinforce. We want to find ways to continue to bring that into that person's life. Because each of us can, while we're breathing, find joy in life. And that is the opportunity and the challenge. Because sometimes it is hard. There's no question about that. But no one guaranteed us an easy life. Sorry, it just isn't there. The opportunity for us is, with the lives we have, how do we make the most joy? How do we bring the most satisfaction and creativity? That we have, each of us. And planning for it allows us to really begin to articulate what matters. There are medical options as well. Clearly, if someone is experiencing a depression, antidepressants can work. If it's a mild depression and someone is cognitively able to participate in psychotherapy, absolutely. That's better than a medication, no question. But if someone is more severely ill or further along in their Huntington's progression, medication may be appropriate and necessary, and they work. Mood stabilizers can work very, very well. Lithium, which is used as the classic medication for bipolar disorder, is one of the best anti-suicide medications we have. It's way underutilized, but it is one. It requires medical monitoring. It requires not having kidney dysfunction, renal disease, but it really reduces suicidal thoughts substantially. A new opportunity may also be ketamine, but to my knowledge, it hasn't been used in people with Huntington's disease. Antipsychotics.
Bob, I just remark on that.
Please.
Because I esketamine, Spravato, literally saved my life. So there's a case study.
There you go. Okay. So thank you. Because just there is not yet a literature on this for people with depression in Huntington's. But that's clearly something, from my own experience, my own clinical practices, ketamine in all of its forms has served phenomenally well to help people making it through a really hard period of life, where they're thinking specifically about ending. And there are lots of other potential therapies. Electroconvulsive therapy has been a standard for severe non-responsive depression for 50 years. And it is a very, very safe approach that now, for those of a certain age, and remember One Flew Over the Cuckoo's Nest, it doesn't look anything like that. It is a modern surgical procedure working with anesthesia in either an endoscopy suite or an operating room. Okay, transcranial magnetic stimulation, TMS, is another technique that we have been using around the world now in the treatment of treatment-resistant depression and suicidality. And it also covers literally using great big old magnets that are carefully positioned around the skull. When you induce an electric current in the brain using magnetism, you can stimulate more neuroplasticity and reduce the symptoms of depression and suicide. So this is being used. And again, as I mentioned, talk therapy can be very, very effective. And depending upon the issues, there are many different kinds of psychotherapies. Really most of them are either cognitive behavioral therapies or interpersonal relationship psychodynamic therapies that can work really very well. For over a year now, we've now had a national crisis line, 988. It receives a little over 1 million calls a day. And it is For many, you can just call and talk to people and be immediately, dealing with a counselor who can help. For others, they can then be given resources more locally available. But a lot of people just need someone to talk to in the moment. And this crisis line can serve and is serving very effectively. It continues to grow and to be manifest probably another 5 years before it's really full blown. So, bottom line, knowing the risks means we can make a difference in people's lives. We can talk about it, we can establish in advance lines of communication because we know that the risks are there for so many of us and the ones we love. Talking about it, planning what to do, focusing on learning what is it that matters to the person with Huntington's, articulating it really in a very concrete way. What matters to you? I want to be here to see my grandchild's birth, my grandchild graduating from college. I want to be here for the next football season. I want, different things matter to us. And so it's important to know what matters to the person you care about. Make it as concrete and clear as possible. And if it's for yourself as well, for all of us, this really matters. Knowing what matters to us, know what gives us joy, know at each stage of our lives what we can do to reinforce that. So we take joy in being alive. We can do this. It takes work. It's not always comfortable, but it's something we can do. Comments, questions? It is really a difficult question to pose to a physician who is almost by definition dedicated to keeping people alive. But it's not just the issue of keeping people alive, it's the issue of quality of life and self-determination. It's a combination of those. One of the things that we've seen looking at the data is that even when you put in the criteria that there must be a psychiatric evaluation, making sure that no one is depressed and because of an untreated depression, they wish to die, it gets very complicated because many people are never referred for those evaluations. And when people may not have the cognitive capacity to make a medical decision for themselves, if it's fairly late in the stages of Huntington's, then it becomes medically just unethical. We can't. If they make that decision very early on, then it would be a legal determination in many states, as opposed to a medical one. What my own feeling is that if this was really intended for people who were dying from something such as cancer with intractable pain. That was the target population. People who had bone cancer who nothing would work to keep them out of excruciating pain other than such high doses of morphine that they weren't awake. That was the target population. And you could understand that, where there literally could be no meaningful quality of life. But then it's been this slippery slope of all of these other conditions where many people can take still many years of great joy and pleasure in life and are choosing out of the fear of what might happen in a decade, ending their lives way before that, not knowing what life is going to be. So my own sense is that A, it's complicated, B, there's no absolute right answer for everyone, but I'm afraid that too many people are taking this choice, or maybe coerced into it, because of family pressures to save money, because of the end-of-life care. And when you put that dynamic into it, it becomes very, very difficult ethically to manage it. So there's so many pitfalls with it. As a doctor, it scares me. Thank you for that question.
Still have about 5 minutes for more questions or conversations.
Thank you, everyone. I
Thank
really
you.
appreciate the opportunity.
Thank you.